Buenos días. Quiero agradecer la invitación a la Sociedad de Neurología y Neurocirugía y a su presidente, la doctora López. Estoy muy feliz de estar con ustedes en su maravilloso país. Muchas gracias. Muchas gracias también a Rubén, con quien yo trabajo mucho desde algunos años. Ok, las miopatías. Pueden ver lo global de las... we can see the neuromuscular disorders here, the global presentation. It's 400 different diseases. Miopatias are the bigger group among all those diseases, and it represents 200 different diseases. All of them are rare or extremely rare, and they are little known and not very much taught. This induces what we call wandering for diagnosis, management, and treatment. Clinically, we have different presentations. The disease can be asymptomatic with only increase of CK level or extremely serious. We have symptoms of musculoskeletal symptoms with the motor deficit, amyotrophy, and fatigability. The topography and the age of onset of the symptoms are very important. Other symptoms will orient the diagnosis. Myalgias, myotony, rippling, and the other consequences can be also scoliosis, retractions, and arthrogryposis. Extramuscular symptoms are multiples too: dysphagia, dysarthria, cardiac involvement, ventilation involvement, digestive endocrine involvements, visual deafness, cognitive involvement. Pardon? Parlez plus fort, oui. Ok, je vais me rapprocher. C'est mieux comme ça. Ok. The main investigations which will help for diagnosis will be biology, biochemistry, electromyogram, which Dr. Ruben Balclaudia has told us about, genetica, muscular biopsy with morphology, enzymology, and immunohistology, Western blot of muscle proteins, echographia, and MRI. Otras investigaciones son posibles regarding the orientation. Those are the main investigations that we will request. I shall maybe, one of the most important is creatine kinase level, lactic acid, and for some diseases, maltase acid. This is what we do in our lab. We perform muscle biopsy and all those techniques. We also extract DNA, and the conservation is in ultracongelators. Genetics. We take samples from blood, saliva, urine, or muscle, but the sample that we'll take depends on the type of disease that we are looking for. if we are looking, for example, for mitochondrial disease, blood doesn't help. We'll take above all muscle, urine, or saliva. There are different types of investigations, sequencing, PCR. If we have a specific orientation, we will look directly for the gene mutation. If not, we have to try to understand the group of disease where we are, and we can ask for panels of genes, like for muscle dystrophy, congenital myopathies, metabolic myopathies, abdominal disease, and mitochondrial disease. There are some others. If we still don't have the explanation, we can explore exoma, genoma, and sometimes we work on RNA. The muscle biopsy, usually we take 4 to 6 samples, which are with different techniques. Morphology, biochemics, ATPase, succinodehydrogenase, etc., cytochrome oxidase for mitochondrial, it's important. Immunohistology will identify the proteins. You have an example here with a normal situation, and here a patient with dysferlinopathy and absence of dysferlin. So it's very precise. We can also, in case of inflammatory situation, look for HLA staining. Western blot is another technique. We can also perform biochemical studies on the muscle directly and DNA investigations. Ultrastructure is useful for some pathologies. This is an example of Western blot with Duchenne disease, absence of dystrophin, or dystrophin of abnormal size, which is Becker dystrophy. MRI is used more and more frequently, and in some situations, the diagnosis with MRI is extremely precise. It helps a lot. The classification of the different myopathies is very large. I shall mention some of them. Dystrophic muscular disorders with dystrophinopathies, Duchenne myopathy, Becker myopathy, limb-girdle myopathies, facioscapulohumeral myopathy, Steiner disease, Emery-Deifies, oculopharyngeal can be are the main one. We have the group of congenital myopathies. Canalopathies, we'll see some examples. Distal myopathies, etc. What are the criteria for the classification? The age of onset is important for example, in congenital myopathies. The topography can define, for example, distal myopathies. Here we have a case of facioscapulohumeral myopathy with weakness of the scapular fixators. A mechanism physiopathologic, inflammatory, for example, for myositis. Criteria of morphology with dystrophic aspects. This is a case with trichrome and myotonia, canalopathies is a different topic. This is a representation of the muscle proteins, and quite all the proteins can induce different diseases. For example, dystrophin here for Duchenne and Becker dystrophy, sarcoglycans, limb-girdle muscular dystrophies, alpha, beta, delta, gamma, sodium channel diseases, caveolin, which will give rippling muscle dystrophy. The example of muscular dystrophy, this is the most known muscular disease. It starts before 5 years old with a proximal deficit of the lower limbs, and it worsens gradually. During the evolution, you will have frequently cardiac involvement, cognitive deficit, respiratory deficit. Usually we lose those patients around the age of 16 to 20 years old, but with new treatments we had a lot of improvement. The group of limb-girdle muscular dystrophy, calpainopathy, for example, which will give an atrophy and a deficit of the ischiatic muscles, so we can get an orientation with this when you have these symptoms. Dysphalinopathy can be proximal, but it can be also distal. When you have the association, this will orientate your diagnosis. Congenital myopathies. Central cord myopathy, this is the case. This is a young man with such a disease. This is the family tree and the histological presentation. It's related to a RAE1 mutation, and we have to be careful with this type of patient because it is at risk of malignant hyperthermia. Nemaline myopathy are of different types. We have that represented in Martinique. Disproportion of the type of fibers. One of the family of Martinique has a TPM3 mutation, and they have two presentations histologically. They have a presentation of nemaline for 4 of the patients in this family, and for one patient, it's a presentation like that. So the same mutation gives 2 types of different diseases in the same family. Myotubular myopathy, which is a very, very severe myopathy, centronuclear myopathy, and multiminicore. Miopatias metabólicas sont caracterizadas clinically by intolerance to exercise, myalgia, and rhabdomyolysis. I would like to speak more about this one, Pompe disease, the type 2, because it has the most frequent presentation is early onset Pompe disease, which is of very severe evolution with heart failure, cardiomyopathy, respiratory involvement, hypotony, and the tongue is also big. There is a macroglossia. It's an emergency for treatment because the treatment is available now with Neozim and Nexviadim. We'll speak about that later. Another type of glycogenopathy is Mercadal disease, which is represented in Martinique. The characteristic is the second wind. They can start an effort, but they have to stop because they are weak and painful, and after a while, they will start again and easier. Lipidoses are interesting to detect because some of them can be improved with treatments. Here is a patient, an adult patient with pump disease. You can see the weakness, the amyotrophy, which is quite selective because some muscles are strong. The scapular fixators are very weak, and he has difficulties to stand from his bed. This is his treatment. He has injection of mucin, every 2 weeks. An example of lipidosis, Shannon-Dorfman disease with a pseudohypertrophy. In fact, the muscles are full of fat, and the skin has defects. The skin is dry and ichthyosis. They also have liver trouble with hepatomegaly. Mitochondrial disease is a frequent issue. We have more than 60 patients in Martinique with this type of disease. And it's interesting because for some patients you can help. There are some identified syndromes like MELAS with pseudo-stroke, MERV, cancer, but in most of the presentation, it's not specific. Here is a young woman with, you can see the ptosis, ragged red fibers on her muscle biopsy. She has epilepsy. Her sister has the same type of trouble, and her daughter too. The management of the epilepsy works very well. The treatment with ubicainone, ubidicarinone, and levocarnil gets some relief for the weakness, but it's not totally effective. This older lady with mitochondrial disease, when she came to my office, she was unable to stand up from the chair. She had to be held by 2 friends, and now under treatment with ubicainone and levocarnil, she can stand up easily. She can go in her garden and enjoy her garden. Unfortunately, she refused to do the surgery of the lead, which would be useful for her. Another situation is a man working with big trucks and engines, complaining of pain and fatigability. His muscle biopsy demonstrates cytochrome oxidase negative fibers, what we call clear fibers. You can see the difference with the neighbor fibers. It has been difficult to make the genetic diagnosis with usual investigations. So what has been performed is dissection of those fibers, a number of those fibers, and analysis of the specific for those fibers, and you could identify a mutation with heteroplasmic distribution. So he has a precise diagnosis, and the treatment is so effective that he doesn't even want to come back to see us. He just requests a renewal of the prescription. So we have some results in some cases. It has been published here with a team of Nice in the south of France. This is a case of a patient with dysferlinopathy. Unfortunately, I have no clinical picture, but this one can be proximal and distal. a case of congenital myopathy with myrosine deficit, dystrophic aspect. You can see atrophic fibers, some fibrosis, little fibrosis, myrosine, which is very weak, excuse me. Another case of congenital myopathy, it's much more than a myopathy, it's an encephalomyopathy with myoclonic epilepsy, severe cognitive impairment and weakness. And electron microscopy can show you what we call cylindral spiral. It has been published here. This is much more frequent. Senior disease, which is a dystrophic, myotonic dystrophy. Dr. Blanco just showed you the electromyography presentation. You can see for this young man that, in fact, I have no video, unfortunately. This patient cannot release the finger easily. This one is very stiff and has difficulty to stand straight. It's a very multisystemic disease with baldness, cataract, cardiac involvement with risk of sudden death. So we mustn't miss the diagnosis because it can be prevented with. It can be prevented with, pacemaker and defibrillator. Other symptoms like myotonia can be improved with phenytoin and maxetil. Sleepiness, modafinil. This is another patient with canalopathy, chlorine canalopathy, and myotony. This started when he was a child. He didn't realize he was very stiff. When he was 17, he couldn't play football like his colleagues. And we saw him very late in his life. He was more than 50 years old for this trouble because if he used to fall down when he was walking. He couldn't climb steps properly, and people thought that he was drunk. We first started with genetic of CNR, which was negative, proximal myotonia negative, then ion shell panel gave us the answer with chlorine canal mutation. The treatment was extremely effective. The symptoms disappeared, and he finished his life free of those symptoms. He died from COVID. Treatment of Duchenne dystrophy. We have the data of what we call clinical research, physiotherapy, orthosis, equipment of autonomy, ventilation, surgery of the scoliosis. It's very frequent. For the heart, prevention of involvement with steroid, vitamin 2, calcium, and ESA, which is inhibitors of the conversion enzyme. Actually, there is a lot of research. This treatment I've tried, we use that one since 2014. The name is Ataluren for codon stop, but the result was not very good. We are not convinced that it's effective. Other treatments are arriving with this type of exon skipping, Elevidis, which is genetic therapy, Ginovasta, and another trial actually with this one, with a microdystrophin. What we could, as you could see, there are some solutions of treatment for some patients, but in those two situations, we can consider that it's an emergency to diagnose and to treat. I put spinal atrophy, despite it's not myopathy, but it's really important to remind that because we have treatment, very effective treatment with Spinozaris, Diplam, and Zolgensma available for our patients. Pompe disease, Myosim, and Exviadim actually are available. We have several patients under treatment with Myosim, and we have Pompe disease have a focus, abnormal frequency in French Guiana, in the west part of French Guiana, when we have a special protocol with Martinique in order to start the treatment for those patients before it turns to cardiac irreversible involvement. As a conclusion, we can say that there is a lot of progress in the diagnosis of those diseases. The problem is mainly the treatments. There is a need of intense research for the treatment because there is still a lack for a number of those myopathies. I showed you what was effective, but a number of diseases don't have appropriate treatments. Thank you very much.